Welcome back, dear student. Now we will discuss questions of physiology. And the very first question is about fluid transporters. Now, basolateral membrane of the intestinal epithelial cell contain which type of fluid glucose transporter? Now here you need to remember one thing, that in intestinal epithelial cells, depending on the location, whether it is apical or basal, we have different fluid glucose transporter, right? So in basolateral membrane, yes, Vicky, Rinkesh, perfect. So it is GLUT, right? So if I draw epithelial cells thing like this, so this is the apical part, and this is, so in apical part we have a different glucose transporter, and in the basal part we have a different glucose transport. So in basal is GLUT2, whereas in apical is GLUT. Clear? So please remember this and don't mix up. Yeah. So GLUT2 in basal part and GLUT5 in apical part of intestinal epithelial, and here we have all lumen of gut. This is gut. So remember GLUT2 in basal part of the epithelial cell. Now, first site of hematopoiesis in a fetus. So hemato means blood, poiesis means formation. Yes, hemato is blood, poiesis means synthesis or formation, and the first part is yolk sac. After yolk sac, if I write the sequence, yolk sac is first, followed by liver, very good. After liver, in terms of, you can write spleen, and lastly it is clear. So this is the usual sequence, and you can make a mnemonic out of this, like some people decide to make a mnemonic something like this, right? So this is the sequence: yolk sac, liver, spleen and bone marrow. And of course, if spleen is not given, then directly go for. So this is the usual sequence. Next question: which of the following gases has got the highest affinity for hemoglobin? Yes, anyone? Highest affinity for hemoglobin? Perfect, perfect. So this is carbon monoxide, and so carbon monoxide has got highest affinity for hemoglobin, right? And which kind of anemia will this result? Yes, perfect. What kind of anemia you will find? Any idea? This is which type of hypoxia? I'm sorry, hypoxia. This is anemic. This is anemic hypoxia. And why I am saying so? Because what happens in anemic hypoxia, or even in like anemia, usually in anemia the usual thing is that there is decrease in hemoglobin, and since the hemoglobin is the carrier protein for oxygen, so there is less oxygen content in blood. Clear? So this is the usual pathology in anemia. Since oxygen cannot travel by its own, majority it binds with the hemoglobin. So in anemia, hemoglobin is less. So as a result of this, the content of oxygen in the blood is also less. Now the same kind of picture is seen with carbon monoxide poisoning. Hemoglobin, it was normal here, but since it binds with, or you can say carbon monoxide binds with hemoglobin, so very less is available for oxygen. Very less is available for oxygen, right? And whatever the content of oxygen in blood is actually the one which we measure as hemoglobin O2. So it means less hemoglobin for oxygen, it means less oxygen content in the blood, right, in relation to the bonded form with hemoglobin. So that gives a picture of anemic hypoxia, because the carrier protein is not available to transport the oxygen. So this is a kind of anemic hypoxia. So carbon monoxide poisoning will give you a picture of anemic. Clear? Because some students, they might at time get mixed up with histotoxic. Not histotoxic, it's anemic. Cyanide is histotoxic. Perfect. Now next question. First heart sound coincides with which phase of cardiac cycle? Yes, everyone is correct. This is start of isovolumetric contraction. Now what do we mean by this word isovolumetric contraction? Iso means same, right? Volumetric means the volume of blood, and contraction is of course the contraction of ventricle. Now what is that condition when the ventricle is contracting but still the volume of the blood in the ventricle is same? That can happen only if both the valves above and below are closed. So suppose if we are talking in terms of left ventricle, you can say that it is mitral valve is closed, and lower down it is aortic valve is closed. And when the left ventricle is contracting as a closed chamber, right? So this is IVC for left ventricle, IVC of left ventricle. So that is the concept of isovolumetric contraction. The valve above is closed, the valve below is. So when the atrium is contracting, the blood will be pushed from the atrium into the ventricle. After that, which is the left side, the mitral valve will close, or if it is the right side, the tricuspid valve will close. So after that, AV valve will close, and that will produce the first heart sound. Semilunar valves are already closed, so the valves above and the valves below both are closed. Now the ventricular cavity is a closed chamber, and when it will start contracting, that will be known as isovolumetric contraction. So the first heart sound ends with beginning of isovolumetric contraction. Here, so remember this. Now, third heart sound is heard because of. Yes, Raghu, Rinkesh, Nidhi. Yes, this is mid diastolic flow in the ventricle. Now, when the ventricle is in diastole, it will receive blood, right? It will receive blood, and there are two phases. One is early phase, early rapid filling, and second is the late filling phase. Now this late filling phase is because of atrial contraction. Yeah. So this early rapid filling phase will produce the third heart sound, and this atrial contraction will produce the fourth heart sound, right? So if someone asks you what is the cause of third heart sound, then you will say that it is the early rapid filling phase of ventricular diastole. Yeah. And atrial contraction, this will give you S. Clear? This AV valve is S1, semilunar is S. Right? Remember it, something like this sequence. I guess everyone is clear in this. So third heart sound, it is early rapid filling phase or ventricular diastole. Now, next question, large V waves are seen in which condition? Okay, good, yes. So this is tricuspid regurgitation. Now let us discuss the different waves of JVP. So JVP has got positive waves and negative. Positive waves are seen if there is increase in blood flow in the right atrium. JVP is actually reflecting pressure changes of right atrium, right? So increase in blood flow or increase in, and if you reverse the facts, it will be the negative waves. Decrease in blood flow, or you can say in simpler terms, you can write outflow. Outflow will be better. So increase in outflow from right atrium to right ventricle, or decrease in pressure, which we will see in cases of atrial relaxation. So these are the, yes, so these are the points which are associated with positive waves or negative waves. Now there are 3 positive waves, A, E, D, and 2 negative waves, X and here 3 positive waves and 2 negative waves. Now what is the reason for positive wave A? A is because of right atrial contraction. Here, so there is right atrial contraction. Then we'll take V first. V is because of increase in blood flow in right atrium. Yes, right. So V is because of increase in blood flow in right atrium, and in between the two there is one positive C wave. These are all positive waves. So this is because of bulging of tricuspid valve because of right ventricular contraction. Clear? So this is the reason. Yes, you can write it venous filling. Same thing, right? So these are the reasons for the positive waves in JVP. Now we'll go to the negative waves, X and Y. X is because of atrial relaxation, right? If there is contraction, there has to be relaxation. And Y wave is because of flow of blood from right atrium, right? Clear? So this is the description for the waves of JVP. Of course, these are the negative. Now we'll come back to the question proper, which is about large V waves. It means it is asking about V waves, and V waves is about the flow of blood within the right atrium or the venous filling of the right atrium. Now what happens in cases of tricuspid regurgitation? Suppose this is tricuspid valve, and above there is cavity of right atrium, right atrium, right ventricle. Now usually the blood is coming from vena cava, superior and inferior, right? So it is coming from superior vena cava. So this blood is already coming into the cavity of right atrium, but there is additional amount of blood which is coming from right ventricle because of tricuspid regurgitation. So the amount of blood within the cavity of right atrium is more, and therefore, in simpler words, if the venous filling is more, V wave is going to be more prominent. So larger V waves, tricuspid regurgitation. Please remember. Okay. Then next question, GLUT2 transporter, what is the location? We have already discussed one in the basolateral membrane of intestine. Now, out of these all options, which is the location for GLUT2 transporter? Yes, anyone? Very good. So the answer is liver. Apart from liver, apart from intestine, liver is also an important place for GLUT2 transporter. So for GLUT2 transporter, you can remember the mnemonic LPS, that is the levator palpebrae superioris, and write LPS here. So L is for liver, P is for pancreas, initially beta cells, and S is for small. Again, this is basal part. Clear? So for GLUT2, you can remember these three things at least, LPS. And for another important which everyone should know is the GLUT4. And for GLUT4, you can remember the mnemonic SAC. Here you can remember the mnemonic SAC. S is for skeletal muscle, A is for adipose tissue, C is for cardiac muscle or myocyte. So at least remember these two, LPS for GLUT2 and SAC for GLUT4. And what is more important, this is insulin dependent. Please remember the GLUT transporters, because this is a very favorite question for exam setter. And GLUT5 we have already discussed in the cycle part, epithelial cells. Please remember this. Yes, Pratusha, right. Insulin dependent. Now, next question. Again, based on JVP. What finding in a case of cardiac tamponade? What finding in cardiac tamponade? Very good. Absent Y descent. Now, what is cardiac tamponade? There is collection within the pericardial sac, right? Yes, prominent X. There is rapid collection in the pericardial sac, and this hampers with the normal physiology of the heart. This is cardiac tamponade. Now, what does the word tamponade means? Tamponade means actually pressure effect. So that collection, yes, backstride, very good. So that collection is actually pressurizing upon the, therefore it is affecting the normal physiology of heart, and we will find a prominent X and an absent Y descent. And what was the reason for Y wave in JVP? Y wave in JVP, the negative wave, because of flow of blood from right atrium to right ventricle, right? So absent Y descent in cardiac tamponade. Of course, back triad is it down, right? One is low blood pressure, and is muffled heart sounds. It will be, yes, it will appear as if the heart is beating at a very distant place. So muffled heart sounds, because the collection which is around the heart is a poor conductor of sound. And third is, of course, raised jugular venous pressure. Yeah, this is the back triads for cardiac. Anyway, please remember absent Y descent in a prominent. Now, next question, tall T wave. So tall T wave and a wide QRS, increased PR interval. All this goes in favor of, yes, I think everyone is right, hyperkalemia. Now, hyperkalemia, what is the normal value for serum potassium? 5.5 pulse equivalent per liter. Right? So whenever we are saying hyperkalemia, so the value will be more than 5.5 pulse equivalent per liter. Here, good, Raghu, good. Now, as soon as the value increases, there is all tented T waves. So this is in fact one of the earliest manifestations on ECG in a case of hyperkalemia. Tall tented, tall peaked T waves, you can write, and then wide QRS. Wide. And if I say wide QRS, what is the normal duration for QRS? More than normal is 0.08 to 0.1, so 0 or 0. And treatment wise, what we can give? We can give insulin plus dextro. Why insulin? Yes, Pratisha, you are right. Why insulin? Because insulin promotes intracellular movement of calcium. But at the same time, insulin can cause hypoglycemia. Therefore, you should also give dextrose. Otherwise, if you give plain insulin, a patient might develop hypoglycemia. So, dextrose is given to counteract hypoglycemia because of, clear? This is a little bit about hyperkalemia. Now, what clinical manifestations can occur because of hyperkalemia? There can be cardiac arrest can occur. So just remember this much for hyperkalemia, which is one of the important topics in imbalancing. Arrhythmia, yes, cardiac arrest. Now LH, next question. LH, Susha, you are right. LH surge, what you will see? There is increase in estrogen and there is low progesterone. Now, if you remember, LH surge means there is a peak in LH value, and this occurs just before ovulation. So this is which phase of menstrual cycle? This is which phase? Follicular phase. And in follicular phase, estrogen is high, progesterone is very good. Progesterone increases in luteal phase. If I show you with a diagram, you can see here, this is the LH surge, and you can see raised estrogen, and you can see low levels of progesterone. So LH surge associated with raised levels of estrogen, progesterone levels are usually. Yeah. So this is LH surge. And here one more thing, whenever we talk about ovulation, what is the time period for ovulation in a menstrual cycle? Yes, perfect, Patricia, perfect. It starts around 24 to 36 hours. We're here. and just peaks about maybe around 10 to 12 hours before the ovulation. Now, ovulation, whenever we count it, we always count it with respect to the next cycle. So what we will say, 14 days before the onset of next. Yeah. So this period is constant. This period is constant, and this period is variable. Clear? So always and always, it is always safer to say 40 days before next cycle. Yeah. This is the period of ovulation. Now, coming to the next question, galactokinesis. Galacto is for milk. Kinesis is, you can say, movement. Any idea? There are two terms, galactokinesis and galactopoiesis. Everyone is correct. So this is oxytocin, and this is released from posterior pituitary. Answer is right. So if I use the word galactopoiesis, for galactopoiesis is milk production. This is under prolactin. And if I say galactokinesis, this is milk ejection, and this is under effect of. Please read the word properly before answering. And yes, this is from anterior pituitary. And for oxytocin, it is synthesized in hypothalamus. It is formed in hypothalamus, and through the hypophyseal portal system, it is sent to posterior pituitary for storage. And once there is appropriate impulses, it is released. Yeah. So this is for oxytocin. Very good, Raghu. So please remember this in terms of breast milk. Right? And for prolactin, it has a positive factor, is promoting its release, and there is an inhibiting factor which can affect the release of prolactin. So TRH promotes release of prolactin from anterior pituitary, whereas dopamine, it opposes the release of. Now, insulin mediated GLUT4 transport. We already discussed that GLUT4, it is present in sac, so skeletal muscle, adipose tissue, and cardiac muscle, and this is insulin dependent. Yeah. And this is which type of transport? Yes, very good. So facilitated diffusion. Now, what is this word diffusion? What do you mean by the word diffusion? Diffusion means there will be movement of a particle from high concentration to low concentration. High concentration to low concentration, and since this flow is in accordance, yes, high to low, very good. So since it is in accordance with the simple principle, if there is high to low, it means there is no energy required. So no energy is required, and this is actually passive diffusion. Right? Active thing requires energy. So this is passive diffusion. There is no requirement of energy along the concentration gradient. Yes, perfect. And in facilitated, now what is this word facilitated? Facilitated means, in simpler words, you can say promotes. So facilitated diffusion, it means it will promote the diffusion along the concentration gradient. Yes, of course, using carrier proteins. So this is facilitated diffusion, which is a sort of passive transport. Yes, Raghu, you are absolutely. So GLUT4 insulin mediated transport is actually facilitated diffusion. Please remember. Next question. Uterine contractions results in cervical dilatation and followed by delivery. Same mechanism is also noticed in, yes, Pratusha, right? So this is milk ejection reflex by oxytocin, because both the phenomena are carried out by, so uterine contraction is also because of oxytocin, and this is also because of oxytocin. These are the same effects at different locations. Now, a lady delivered a baby, but she is not able to breastfeed because there was no milk production. Now, which of the hormone is inhibiting milk production? This we have already discussed, because whenever we say milk production, we are talking about which hormone? We are talking about prolactin, right? And we discussed that prolactin is inhibited by dopamine from thalamus. This is the answer is very straightforward. This is dopamine, right? So this is dopamine. Prolactin is inhibited by dopamine. Now, next question. Which of the following has nothing to do with serum calcium level? Answer is very straightforward, I guess. Anyone? No active role of insulin as such. Now, parathormone, it is released from gland. Yes, everyone is right. So this is released from parathyroid glands, okay, and the function of parathormone is to increase serum calcium levels. And how it increases the serum calcium levels? By promoting classes, promoting calcium. Clear? Now, what is this osteoclasis? This is bony absorption, because we know that the bones, they are the bank, calcium bank. So there is a continuous withdrawal of the calcium from the bones. There is absorption of calcium, and that is known as osteoclasis. So parathyroid hormone, it promotes that activity and it to increase the serum calcium level. Now, what is this calcitonin? What is calcitonin? Okay, right. Coming to calcitonin, what is calcitonin? Is released from which? What is the source of calcitonin? Anyone? Calcitonin, it is released by, yes, it will decrease calcium levels. Yes, decrease. It is released from, what is the source of calcitonin in the body? Very good. So this is T cells, which are also known as parafollicular cells, known as parafollicular of thyroid. Yeah. So it decreases serum calcium level and principally is decreases to acid. Yes, yes, perfect. So parathormone and calcitonin, they are antagonists of each other. One tries to increase the serum calcium level, other tries to decrease the serum calcium levels. And just remember this much about parathormone and, yeah. So insulin not discussed. Which of the following is reabsorbed almost completely in PCT? Yes. Of the following is 100% reabsorbed from the kidneys? Perfect. The answer is glucose. Glucose is reabsorbed 100%, and there are two 100% reabsorption is two things. One is of course glucose, and what is another thing? Amino acids. Yeah. So these two are 100% reabsorbed. They should not come in urine in a normal person. Glucose and amino. Next question. Main role of angiotensin 2. Main role of angiotensin 2. And yes, we are talking about the renin angio aldosterone or axis. So the correct answer is increase in total peripheral resistance. Right. Now, what is the ultimate effect of this renin-angiotensin aldosterone system? It tries to increase the blood pressure. Right? So the ultimate effect is to increase blood. Yeah? Yes, vasoconstriction. Yes, to increase blood pressure. Now it involves series of steps. Whenever there is hypotension, so the initial is angiotensinogen, which is coming from liver, and this is acted upon by renin, and it is converted into one more inactive substance, that is angiotensin 1. Now this is inactive. Clear? Angiotensinogen is also inactive, and we know that all the proteins are synthesized in liver except gamma globulins. So angiotensin 1 is also inactive. Now this angiotensin 1 is acted upon by ACE enzyme. So it is acted upon by ACE enzyme, and it is converted into the active form, that is angiotensin 2, and this occurs in, this is synthesized in lungs. So angiotensin 2 is formed, and this is active form. So it will do two work. It has two actions. Number one, it will promote release of aldosterone, and number two, it will cause vasoconstriction, or in simpler words, it will increase the total peripheral resistance. Right? Now this aldosterone, what is the effect of aldosterone? It will promote increased water sodium resorption. Right? Is water and sodium resorption. So this all will ultimately lead to increase in blood pressure. Now, how this concept can be correlated clinically? Because if you know that we use ACE inhibitors for treatment of hypertension. So if we use any drug which inhibits ACE, and this will block this cycle, and there will not be increase in blood pressure. So that ACE inhibitors or pril kind of drugs, captopril, lisinopril, ACE inhibitors, they block this particular part, so they prevent conversion of angiotensin 1 to the active angiotensin 2, and therefore this whole cycle cannot be completed. The blood pressure does not increase at all. Right? So that is the clinical correlation of this whole cycle. So here the ACE inhibitors will act. Yeah. So this is renin-angiotensin aldosterone class. Yes, Nidhi, you are right. Now, next question, inulin clearance. Don't mix it up with insulin. This is inulin clearance. It closely resembles GFR. Yes, good, Raghu. And whenever we are using any substance, so the ideal substance to measure GFR should have at least two properties apart from being safe also. Number one, it should not be reabsorbed, right? And number two, it should not be secreted. So it means none of the substance should be taken back from the kidney, or none of the substance should be given by the kidney. So that way, whatever the amount of that substance is coming out, that will be equal to the GFR. So that is the ideal property of a substance if we are using it for measurement of GFR. And yes, safety should be first, it should not be toxic to the humans. So inulin closely resembles GFR because neither it is secreted nor it is reabsorbed. So it equalizes GFR. Now, next question, if someone has taken a high carbohydrate diet, what will happen to the hormones which are concerned with the metabolism of glucose? So what will be seen after a carbohydrate rich diet? Yes, perfect. The answer is decrease in glucagon and increase in insulin. Now, if somebody is taking carbohydrate rich diet, what will happen? This will lead to increase in blood glucose. And how body tackles raised glucose levels? By promoting insulin and decreasing glucagon because it is hyperglycemic hormone. So glucagon levels will be less, insulin levels will be high, which will avoid hyperglycemia, which has resulted because of increased intake of carbohydrates or in the form of carbohydrate rich diet. So whenever there is hyperglycemia kind of picture, insulin levels will be raised, glucagon levels will be low, and this will make sure that the blood glucose are within the normal range. It doesn't increase too much. So this is the usual hormonal. Yes, right, Pratyusha. Now next question, secretin. What is the best stimulation for release of secretin? Very good, Raghu, very good. So it is, the main is acidic chyme. Sorry, main is acidic chyme. Now here we can take the clinical picture first. Now what happens? Suppose stomach, then duodenum. What happens? The stomach is very well developed to tackle the acidic environment. So here we know that HCl is there, which is very acidic, but the duodenum doesn't have an inherent mechanism to tackle this acidic thing. What happens? As soon as this acidic chyme enters into the duodenum, there is possibility that this acid might injure the duodenal mucosa. So this acidic chyme can injure the mucosa of the duodenum, and therefore we see that there is possibility of duodenal ulcer. Right? So what happens? There is a nature's there is a nature's mechanism to prevent this acidic injury to the duodenum, and that is in the form of here. So secretin is also known as nature's. So whenever the acidic food comes into duodenum, there is a reflex signal which goes to the S cells of the intestine, and they release secretin, and secretin, it promotes release of watery pancreatic secretions, which will neutralize acidity, right? So this is actually alkaline, right? So this is to neutralize the acidity of the acidic chyme. So this secretin, yes, increases bicarbonate. Yes, so actually bicarbonate. This is the non-enzymatic part. We know that pancreas is both exocrine as well as endocrine. So this is non-enzymatic part, and this just is alkaline, so it just tries to neutralize the acidity of this acidic chyme, and this prevents injury to duodenum. So please remember this much: secretin, the main function is to neutralize the acidic thing, whatever is coming to duodenum, and this also prevents the injury to the duodenal mucosa because of that acidic content. Right? So secretin is nature's antacid, and released by S cells of small intestine. Clear? So acidic stuff is the main stimulation for release of secretin. Next question: Brown-Séquard syndrome. So sensation lost on the same side in Brown-Séquard syndrome are all except. Yes, anyone? So Brown-Séquard syndrome, which is also known as hemisection the spinal cord. Now, when I say hemisection, it means half of the spinal cord is damaged. Now, to understand this particular question, we should know the anatomy of the spinal cord first. So suppose if this is spinal cord is anterior, so here we have dorsal column. The shell is dorsal column, and here we have lateral spinothalamic tract. Lateral spinothalamic. So this is the arrangement. Fasciculus talis, and now we should know what modalities are carried by these ascending tracts. Now these are ascending tracts. So dorsal column carries what sensations? Yes, you are right, Pratyusha. Medially is fasciculus gracialis, laterally is fasciculus. Dorsal column carries which modalities? One is proprioception, and another is stereognosis and vibration, fine touch, 2-point discrimination. Now, these are the modalities which are carried by the dorsal column, and fasciculus gracilis is for lower limb and fasciculus cuneatus is for upper limb. Clear? It means the proprioception, stereognosis or vibration from the lower limb will be carried by fasciculus gracilis, and from the upper limb it will be carried by fasciculus cuneatus. Number one. Number two, what about decussation? Decussation occurs at the level of medulla. Clear? So the first order neurons of the dorsal column, they ascend till the medulla and then they change over their direction and they ascend as the medial lemniscal system till thalamus, right? So decussation occurs in medulla. Perfect. Now we'll take the another tract, and that is spinothalamic tract. Spinothalamic. I'm more interested in lateral spinothalamic tract. LST. What are the modalities which are carried by lateral spinothalamic tract? I'm more interested in discussing lateral. Lateral carries pain and temperature. Right, Raghu. So pain and temperature are carried by lateral spinothalamic tract. And now, even more important thing is about the decussation or crossing over. What is the point of decussation of lateral spinal? Where we see decussation. What is the point of decussation of lateral spinothalamic tract? Very good. It is at the level of spinal cord only. Clear? Now, having discussed these two important modalities and the level of decussation, now we can discuss the clinical entity as such. So, suppose if this is the left side of the patient, this is the right side of the patient. Okay. Now, if there is complete injury to the left half of the spinal cord, there is complete injury to the left half of the spinal cord. It can be because of chop wounds or bullet injuries. So now what will happen? It will involve the spinothalamic tract, the lateral spinothalamic tract, and it will involve the dorsal column. Now the dorsal column modalities which are affected on the left side are actually the one which is taking the impulses from the left side only, right? So this one is from the left side only. So whatever the modalities which are going to be affected on the same side are the one which are carried by the dorsal column. Now here the lateral spinothalamic tract which is injured, it is actually the one which has come from the other side and then has crossed, right? So the lateral spinothalamic tract which is present on the left side is actually the one which is coming from right side, and since it has crossed at the level of the spinal cord only, so it will be affecting the sensations of the opposite side, right? So opposite side is lateral spinothalamic tract. Clear? Same side dorsal column, opposite side lateral spinothalamic tract, because the decussation or the crossing over has occurred at the level of spinal cord only, and if half of the spinal cord is injured, it means it will affect the fibers lateral spinothalamic tract which are actually taking the sensation opposite side. Clear? So opposite LST, same dorsal column. So the answer you can write is pain. Right? So this is the basic description for this entity which is known as Brown-Sequard syndrome or hemisection of the spinal. Okay? So you just need to know the course of the tract and the modalities which are carried by them. Now, what is this proprioception? Any idea what is proprioception? Any idea what is proprioception? This is joint, yes, joint position sense. If suppose if we close our eye and if someone manipulates our joint, we can identify that what position our has been given to our joint. So that is joint sense. What is stereognosis? Any idea what is stereognosis? Yes, Raghu, you are right. Stereognosis. Any idea? Stereognosis means if we close our eyes and if there is no auditory input, and if somebody gives some object in our hand, we will simply feel it by the fingers, and we can answer that this object has been given in my hand. Suppose if I give in a pen, I can simply roll it in between my fingers, and by the touch only I can say that this is a pen. So that is known as stereognosis. Yes, identifying object without any auditory or visual hints. Right? So proprioception and stereognosis. Anyway, so next question. Atrial and saccule in the inner ear. Yes, many of you have already answered that. It is linear acceleration, and yes, for angular acceleration, this is semicircular canals. Perfect. Now, next question. Yes, right, semicircular canals. If there is a damage to a brain structure, after which there is less appreciation of fear, which structure might have been damaged? Yes, amygdala, right. So amygdala, this is for perception of the fear, and if amygdala is injured, the person might become fearless, so he won't appreciate the fear, right? So this is about amygdala. So response related to fear. Now, next question. Elderly patient with a history of stroke, now having stroke involving the inferior frontal gyrus, what would be seen? So there is injury or there is involvement of the inferior frontal gyrus. What can we expect? So this is the lateral sulcus here. This is the inferior frontal gyrus. Inferior. This is inferior frontal gyrus, and inferior frontal gyrus contains Broca's area. This is Broca's, and Broca's area is also known as motor speech. Clear? So if there is involvement of the inferior frontal gyrus, what will happen? Patient will have affection of the motor speech. Yes, perfect. Right? So now we can just take few words about aphasia. Yes. Aphasia means this is the disorder of speech. Again, we have two types, can be motor, can be the motor is also known as non-fluent, and this is also known as fluent. It's also known as Broca's, it's also known as Wernicke. Now what happens? Motor area is about, you know, the expression, and Wernicke's is about perception. So if there is any damage to the Wernicke's area, what will happen? Patient will not understand what is being asked. So impaired comprehension. The patient will not understand what is being asked, but whatever he will say, the speech will be fluent, but not related to the question. Clear? So the patient will speak very smoothly, but it won't be related at all to the question, because the point or the area which is concerned with the understanding of the question is damaged, right? So speech is fluent but no way related. In cases of motor aphasia, patient will understand the question nicely, but he will not be able to reply in a fluent speech, right? So non-fluent speech, but answer is related to the question. Clear? In Broca's, he will reply, yes, you can say word salad. So this is in short about aphasia. And of course, the location of this is inferior frontal, and the location of Wernicke's area is superior. Clear? Please remember this much related to aphasia. Now, next question. There is a case of head injury. The person can write normally, can copy easily, but is not able to speak fluently. What can be the site of lesion? I think everyone can answer this. This is Broca's area, because there is non-fluent. Thing doesn't need any more discussion. Which is not seen at high altitudes during the process of acclimatization. So not seen at the high altitude. Yes, whenever we go to the high altitudes, body needs more of oxygen, because the partial pressure of oxygen is less at high altitudes. Especially if you have ever gone to Ladakh, you must have felt that. So yes, hyperventilation is, you need to hyperventilate. So not hyperventilation, there has to be increased ventilatory rate, that is hyperventilation. Here, it's not hypo, it should be hyper. Yes, everyone is right. Now, what is this Bainbridge reflex? What is the effect of Bainbridge reflex? Yes, Pratisha, you're right. What is the effect of Bainbridge reflex? Bainbridge reflex finally leads to tachycardia, right? So it will finally lead to tachycardia. So whenever there is increase in blood venous return, there is inhibition of the parasympathetic activity in terms of inhibition of the vagal tone, and this ultimately leads to increase in heart rate. Right? So this is the effect of Bainbridge. Thermoregulatory center. It is present in which part of the brain? Hypothalamus. Yes. So hypothalamus has two areas which specifically relates to the temperature, high temperature or low temperature. If there is low temperature, this will lead to shivering. This is controlled by posterior hypothalamus. And if the body is exposed to high temperature, there will be sweating. This is controlled by anterior hypothalamus. So hypothalamus, it has the thermoregulatory center, and it determines the body response to the temperature to which the body is exposed. Low temperature, shivering, that is for generation of heat, controlled by posterior, and sweating to lower down the body temperature, controlled by anterior. Now, what will be the effect of low temperature on oxygen hemoglobin dissociation curve? Low temperature will shift the curve to left. And when I say the curve has shifted to left shift means what will happen to the oxygen? Will it be still attached or will it be liberated? Oxygen remains bonded to hemoglobin. Right? So there is no release. And if I say right shift, It means the oxygen will be liberated. Very good. Oxygen is liberated or released from hemoglobin. So depending on the conditions, yes, left favors affinity. Very good. So left shift, it means it will remain attached. In right shift, where we can find the right shift? What are the conditions? Like especially if there is increase in PaCO2, which will lead to fall in pH, or size which increase O3, PPG, anemia, raised temperature. So all those conditions will favor release of oxygen from the hemoglobin, or we will say that the curve has to right, and all the opposite conditions will shift the curve to left. So this is right shift or left shift of the oxygen hemoglobin dissociation curve, and the shape of oxygen hemoglobin dissociation curve is sigmoid. You can say S shaped curve. Now, which of the following explains the delivery of oxygen in fetal circulation? Which of the following rules explains the, yes, Krishna, you are right. Delivery of oxygen in fetal circulation is no, this is about delivery. Means curve will shift. So this is the shift of curve, and related to HPF, it has high affinity, of course, high affinity for oxygen, and it will shift curve to left. Here will shift the curve to left, but here the factor which is responsible for release, and that is because of increased PaCO2, which leads to fall in pH, and this results in right shift of oxygen hemoglobin dissociation. Right? So this is Bohr effect. This is how the oxygen is released. So please remember Bohr effect, and this causes right hemoglobin. Clear? Dopamine in low doses causes, what is the effect? We take dopamine, effect varies as per the dose. Low doses, high dose. What is the effect of dopamine in low dose? Anyone? Yes, anyone? In low dose, it causes renal vasodilation. It is renal vasodilatory in low doses. And what is the effect in high dose? High dose, it is positive inotropy. Right? So low doses, it is renal vasodilation. And what do you mean by the word inotropy? Inotropy means force of contraction, heart, especially left ventricle. Right? So if we say positive inotropic effect, it means it will increase the force. So this is in relation to dopamine. The effect varies with the amount of dose. Now, next question. A 5-year-old boy is having difficulty in walking, right? And when he was 4 months ago, his mother realized that he is having trouble in rising from the floor. This is important. Calves are bilaterally hypertrophied, and Whenever he rises off the floor, he supports himself with his hands on the thighs. Now, which substance deficient? Clinical presentation for Duchenne muscular dystrophy, DMD. What should be the answer? Dystrophin gene. Right? So, in the clinical presentation, you are getting two important points. Number one is this, and number two is, now what is number one? Valves are bilaterally hypertrophied. Very good, Pratyusha. Now here, the size of the calf muscles is more, but if you check power, less power, right? So therefore, this is known as pseudo hyper, because usually what happens, size of the calf muscle or any muscle is more, the power should also be more. But here what is happening, from a distance the calf muscles are looking very bulky, but when you will check power, it is going to, so we have used the terms number one. Now what is this number two? Number two is a classical sign of Duchenne muscular dystrophy. And what is this sign? Anyone? This classical sign? Power sign. Power sign. And this is the classical way of patient getting up from the floor. Whenever he will stand up, firstly he will take the support of the floor, then he will take the support of the knees, and then only he will be able to stand up erect. So it feels patient is climbing over himself. This is the usual description, that unique way of getting up from the floor. So these 2 points are very important for Duchenne muscular dystrophy. Now next question. A lady was watching TV for long hours and she kept her hand under the head. Later on, she developed tingling sensations. Now, which nerve fibers will be affected? Now here, this is actually the pressure effect. So this is the pressure effect. And we have the sequence in terms of susceptibility to pressure, and that is sequence is ABC. So the answer would be fibers type. So A fibers are most susceptible, followed by B. The answer is A. Right? Now, if you remember about A delta fibers, what are A delta fibers? A delta fibers, they are mediator for fast pain, and C fibers, it is mediator for, right? So A delta carries fast pain sensations, C fibers. Very good. So pressure, remember the sequence AB, right? Now, which protein prevents contraction of a skeletal muscle by binding on the active sites of, if suppose this is actin, and now actin has some active site. These are active sites, and for contraction to take place, the myosin head, myosin for contraction to take place, the myosin head should bind with these active. Now at rest, when there is no contraction, there is a protein which is covering these active sites. At rest, there is a protein which is covering these active sites, and that is known as tropomyosin. So tropomyosin covers the active sites of actin at rest, and therefore it prevents contraction at rest. Right? Otherwise, if there is no protein, the myosin head will bind with actin, and that will lead to muscle contraction even at rest. So normally, this contraction process prevented at rest by tropomyosin. And yes, once there is a command for muscle contraction, the calcium will be released, and that will bind to troponin, and that will remove this tropomyosin from here, and that will expose the active sites so that the myosin head can bind with those active sites, resulting in muscle contraction. So the one which is preventing muscle contraction at rest is tropomyosin. Clear? So this is tropomyosin. So if you can look in the image, this is tropomyosin. This pink colored structure is tropomyosin, and these blue dots are actually the active sites, and these is actually the actin. Clear? So whenever there is whenever there is a stimulus, calcium is liberated. This calcium binds with troponin, and that displaces the myosin, exposing the active sites. So you can see the active sites are exposed. Now the myosin head can bind easily. Clear? So the answer has to be tropomyosin. Now next question. What will be the effect over GFR if there is a fall in efferent arteriolar resistance? Now let us draw a diagram for this. Suppose this is glomerulus. Here is efferent arteriole. This is efferent arteriole. Then this is all here like this. Now the question is about fall in efferent arteriolar resistance. It means there is dilatation of efferent arteriole. Fall in resistance means there is vasodilation. Now if there is vasodilation, it will promote flow of blood, therefore GFR will decrease. There will be a fall in GFR. Here, if there is vasodilation of efferent, it will lead to decrease in GFR because blood will flow out from the glomerulus very easily. Now on the other hand, just reverse it. If there is an increase in arteriolar resistance of the efferent, it means there will be contraction or there will be narrowing. So the blood will remain in the glomerulus for a longer period of time. So that will lead to increase in GFR. Right? So efferent vasodilation, fall in efferent vasoconstriction will lead to increase in. Now reverse the parameters for efferent arteriole. Right? So if in efferent arteriole, the efferent arteriole, if there is vasodilation, it means there will be more blood, so this will increase GFR. And if there is vasoconstriction, there will be less blood flow to glomerulus, so there is less. Clear? So please remember this relationship of efferent or efferent arteriole with respect to the state of their muscular activity, whether there is vasodilation or whether constriction. Clear?